Hey, my beautiful dental squad. Welcome back to the series of Mission MDS 2024. So, this is a video on oral radiology rapid revision in which we'll be seeing about radiographic interpretations of various important diseases. So, in this, I'll be covering a few diseases, and with this, we'll end the oral radiology revision. And with the other diseases, I'll like discuss it along with the pathology, medicine, and other points also. Okay, so let's just see what all we can discuss in this. This thing is like we'll discuss about intraoral radiographs, extraoral radiographs, common dental and maxillofacial pathologies. That is, those we are well versed with. Okay, and tips for interpretation, and also about a few points on radiation safety. Okay, so let's just see intraoral radiographs. So intraoral radiographs, we commonly use them for to identify any periapical pathologies. So a normal intraoral radiograph will have a lamina dura, right? Lamina dura, which is the dense part around the tooth, right? So this is the lamina dura, and it will have periodontal ligament space, root apex, right? And a alveolar bone. So these are the normal anatomical features which we see on a normal periapical radiograph of the tooth. So we have to just go for pathologies. So pathologies, what all we see? So we see caries, we can see periapical abscess, we can see cysts. Okay, so as you can see in this radiographs itself, so the caries, right, and you can see the periapical abscesses. You can see how there is a supernumerary tooth, right, and you can also appreciate cysts, right? So when there is increased periodontal ligament space, so you can observe here, there is increased periodontal ligament space, then it is known as periodontitis. You can also find about the root fractures as we can see here, right? So this is like the important point you have to keep in mind is the differentiation between periapical abscess and a cyst. So periapical abscess, how it will be? So how it will be? Periapical abscess. So periapical abscess will have a apical radiolucency which is diffuse in condition with no proper borders. Whereas a periapical cyst, there will be an apical radiolucency, periapical radiolucency covering the this thing, but with a sclerotic border, right? Then coming to the techniques which we can take the intraoral radiographs. Two techniques that we use are paralleling technique and bisecting angle technique. The most common technique that we use in our routine radiography is paralleling technique. This is because paralleling technique helps in keeping the reducing the distortion of the images. Okay, it will provide us the reliable images for diagnosis, right? So in paralleling technique, what we'll do, we'll keep the receptor parallel to the long axis of the tooth. As you can see in this image, the image receptor is placed in parallel to long axis of the tooth. Whereas in bisecting angle technique, we'll keep the image receptor so that the X-ray tube is at like 90 degrees angle to the, it is bisecting, right? It is bisecting the tooth. Okay, it is perpendicular to the bisecting line. So this method is designed to reduce distortion of the radiographic image. So these images you have to keep in mind. Okay, sometimes they may ask an image based question on this, right? So these are the two techniques which we use. Let's see a question here. On a periapical radiograph, you observe a widened periodontal ligament space. That means there is infection in gums around a mandibular premolar and alveolar bone loss extending apically. Okay, so alveolar bone loss is extending apically. So whenever periodontitis infections are given, when there is bone loss, it is that the infection has been there for longer time. So that based on that you can distinguish whether it is acute or chronic. So since alveolar bone loss is there, it means that the lesion was there present for longer time. Then the answer will be chronic periodontitis for this question. Okay, then intraoral radiographs, again one more important one which we have is bite wing. So as you all know, we use bite wing especially to diagnose proximal caries which is hidden or occult, right, which we cannot see in periapical, normal periapical radiographs, or when we cannot see it clinically. So the normal anatomy, we can see the coronal portions of the teeth, alveolar crest bone, and coronal portions of both maxillary and mandibular, right? And interproximal contacts can be seen. We can view caries and proximal periodontal bone loss, right? So we can view proximal periodontal bone loss, right? And also calculus and fractures. So what size of IOPA we can use for bite wing are? Size 4 is used in adults and size 2 is used in pedo. See, these are the important points around bite wing you have to keep in mind. Okay, then coming to a question on bite wing. A bite wing radiograph shows a radiolucent area at the enamel dentin junction on the distal surface of a maxillary molar. What is the most appropriate next step that we do? Is it we observe and monitor or schedule a root canal treatment, place a restorative filling, or order a CBCT scan for further evaluation? See, there is a radiolus area already we are seeing in enamel dentin junction. That means there is distal caries in the maxillary molar. So we will go immediately to make a cavity prep, right? So we will prepare a test cavity there and see whether there is See, we have see whether there is the cavity involving the pulp or not. So if it's involving the pulp, we can see the involvement in the pulp in the bite-wing radiograph itself. So test cavity will let us know the depth above which it is involved. So based on knowing that, we can go for a restorative filling in that area. Okay. Then coming to extraoral radiographs, the main extraoral radiograph that we take commonly is OPG, which is orthopentamogram or panoramic radiograph. It gives overall view of maxillofacial structures. The maxillofacial structures such as teeth, jaws, sinuses, and TMJ. Okay, so the pathology which we can find impacted teeth. So you can see impacted teeth can be seen. If there is any fracture, we can see the fractures sometimes, like these involving like these areas we can see. Okay, and jaw tumor. So you can see here lobulated jaw tumor here. Cysts and sinusitis can also be appreciated in extraoral radiographs, right? So apart from that, we have one more common radiograph that we take nowadays is CBCT. The CBCT gives a 3D view of the maxillofacial structures. So as you can see in this image here, so you can see the same maxilla and mandible in different views. So this will help in like easily locating the pathology, right? So we can easily locate the pathology in a 3D view and then we can go with the treatment. So in OPG, we have a 2D view that will not give sometimes that will not give a proper location, right? But this will give some accurate location, right? So it can be used to assess the bony structures, implant planning, TMJ evaluation. And nowadays we are even using it for root canal treatments to know the exact location of the canal and exact length of the canal and exactly how many canals are there. So the pathology it can show us, it can show fractures, bone tumors, congenital anomalies, and impacted teeth. Radiolucency, well-defined unilocular radiolucency with sclerotic borders between maxillary laterals and canine. What is the most likely diagnosis? So for this, you have to know the how these look in the radiograph and where is the location. So radicular cyst, most commonly it is associated with Pulpitis, right? Chronic pulpitis. So it is seen in the apex of all the teeth and especially mandibular teeth. And coming to periapical abscess. Periapical abscess is also due to chronic pulpitis, which is an abscess, right? So abscess will be diffuse, but borders will be, I have told you already, diffuse borders will be there in abscess, right? And cyst, there will be sclerotic border. And dentinogenic fibroma. Dentinogenic fibroma will have a radiolucency, mixed type of radiolucency. And amyloblastoma, you all know. How will be the radiolucency of amyloblastoma? Comment me. Right. So since they are saying well-defined unilocular radiolucency with sclerotic borders, the option will be radicular cyst. Comment me how the amyloblastoma looks. It is a very important question for you. Right. So let's just see how common dental caries like dental and maxillofacial pathologies look. So dental caries, as we know, it is a radiolucency which can be seen at dentin enamel junction, which is progressing towards the pulp. So how it will be? It will be triangular. Then periodontal disease, widening of the ligament space and alveolar bone loss. Periapical abscess, which will be a radiolucent area around the apex associated with swelling and pain. Cysts will be well defined with sclerotic borders. It can also displace the teeth. Tumors. In coming to tumors, the radiographic appearance is variable. This we'll discuss along with the uh, what clinical features, pathology, and radiological features. Like we'll make a video like that so that it will be easy, right? Then coming to tips for interpretation, you have to know what is what. First point, where dentin ends, where pulp starts, where enamel ends. This is very important for you to know. And compare findings on contralateral side of the same radiograph. And consider clinical presentation and patient history. Use magnification and angulation for detailed assessment. Coming to radiation safety, this is also a very important chapter. So radiation safety is important because we have a few image-based questions on this. So optimization. Optimization is nothing but, see, whenever we are projecting some rays on the biological substance, the radiation should be optimized to certain limit, right? So a certain limit should be there to which the body is being hit by the radiation. So that limit is ensured by proper collimation, that is proper usage of collimator. So to limit the exposed area and to use digital radiography whenever possible, that is to use RVG whenever possible. Okay, as it requires low radiation doses and compared to traditional X-rays. And one more important thing is inverse square law. The radiation intensity increases rapidly when the distance from the source, that is, when the X-ray source is here, when the radiation intensity is decreases rapidly, like the distance between the source and the object, if it is increased, the radiation intensity, what will happen? It will decrease. So this you should keep in mind. This is the inverse square law. So this is how the X-ray is seen. And this is one of the, what is this? Collimator. Okay. Then coming to other safety things, the main important thing is shielding. Lead aprons are must for radiographic technician as well as the doctor that is taking the radiograph. This should be implemented in your clinics. Okay. And these provide effective shielding from what? Scattered radiation and also for the patients. Okay, walls and barriers. So lead lined walls should be used in the radiology rooms. Then protective equipment. We can use thyroid collar. Lead lined thyroid collars protect the thyroid gland, especially for pregnant women and children. Then goggles. Goggles are also very important to reduce the scattered radiation for the eyes. Okay, then again, monitoring and dose limits. So the radiation room should be monitored. Okay, it should be monitored and the dosage should be checked frequently to see how much the is if it is in the limits. So for that we use dosimeters. Dosimeters are three types, that is TLD, ionization chamber, and what is this? What is this? See, you have to have a minimum this thing on dosimeters, right? Okay, we have a reel on dosimeters also. No, I think our story app kept on dosimeters. So it will help in reducing the cumulative radiation exposure. Okay, when they stay and they help in stay within the safe limits. So the types of dosimeters is also very important. So, so So when coming to the types of dosimeters, these are, what are these? Film badges. Okay. And this is ionization chamber. And these are TLD, that is thermoluminescent dosimeters. Okay. So these are the three types of dosimeters that we use in radiation. And the second most important thing is ALARA principle. ALARA principle should be kept in mind. ALARA is nothing but the radiation exposure should be as low as reasonably achievable. Okay, should be as low as reasonably achievable. So this is a very important slide. Make a note of it. Okay, then coming to the effects that the human body will have because of this scattered radiation. So there are two types of effects. One is deterministic effect, the other is stochastic effect. So what is deterministic and what is stochastic? Deterministic is when a number of people are exposed to the same dose of radiation and certain symptoms appear in only a few of them. That is set dose is considered as threshold dose. Okay, when the minimum dose the people are exposing, like it is a normal radiation exposure that the people are undergoing through whenever they are going for a checkup. Okay, so if they produce effects even with minimum exposure to radiation, those are called as deterministic effects, even within the threshold dose. So it might be like hair loss, cataract, skin injury, that kind of things. Stochastic effects. Stochastic effects is like effects of radiation exposure under certain doses are not clear because effects of other cancer promoting factors such as smoking and drinking habits are too large. When this specifies that standards for radiological protection for such low dose exposures, assuming that they may have some effects as well. Okay, so if the patient is having already cancer patient or having smoking and drinking habits, we have to take those also into consideration when we are discussing about the radiographic effects. Okay, so when we assume that effects would appear depending on dose levels and the spontaneous incidents, and when there is no threshold dose being like uh, designed like this, then it is known as stochastic effects. The main thing is deterministic effects will have a threshold dose, stochastic effects will not have a threshold dose. Okay, so this is the main important point that you have to keep in mind. So one question, which principle of radiation safety emphasizes minimizing the radiation exposed to during radiography? Minimizing the area exposed to radiation, ALARA. Okay, so you have to as low as reasonably achievable, which this should be this will help in minimizing the area exposed during radiation. And one more question: a pregnant dental hygienist routinely works with X-rays. What additional precautions should she take from maximum protection? So, first of all, we don't allow pregnant women mostly to be our hygienist or be our radiation radiation personnel, because there are a lot of uh, studies supporting that radiation causes problems for these pregnant women and the baby inside. So, see, the options given are increase the distance from the X-ray source. This is a very good thing that she can follow, and avoid working with radiographs altogether. This can also be done. Wear a lip apron and thyroid collar. This can also be done. See, it depends on the person who is like it depends on the person. So some people avoid completely coming to the radiographs, and that is, of course, it should be done. And increase the distance. Some people do the adjustments involve wearing a leather apron and thyroid collar, and or increase the distance from the x-ray source. So these are the some adjustments they can do. So the precautions that they can take is all of them they can take. Okay, so the answer will be all the above. Okay. So this is a brief about the radiation. Okay, we'll discuss the points on radiation diagnosis and all with other diagnostic measurements. Right? So please do share with your peers and please do revise from the video and be benefited for your NEET MDS 2024. Thank you.